let's jump straight into it, I guess. So thank you everyone for coming today. And I think there's probably a reason why you signed up for this course. I'm sure many of you already knew at least a little bit about EA. Or maybe you're just friends with me and I forced you to come. It could be the case as well. But why effective altruism, right? And why does it matter? I think this crowd over here is going to be very interesting because all of us are in healthcare and that means we already have like a preset level of ambition because we made it to med school and hopefully are getting through med school or already part of med school. There is some level of altruism already. You wanted to do good, which is why you decided to go to this field as compared to like, for example, Ravi, who decided to chase the money. Um, and there's many different ways to do good, right? Essentially, effective altruism is a sort of triaging of the world's problems and how best you can do this with evidence, with reason. And so I'm going to give you guys like this. Imagine if you are this top surgeon in London or Kenya or wherever you are tuning in from. And each week you save about 3 lives. That's pretty decent, right? Good stats. But what if I told you the real impact that you could create is not just from saving the lives in front of you, but maybe saving millions of lives annually? And this is something that we don't really consider because nobody really taught us this in med school. And this is one of the biggest ethical dilemmas that each of us face, which is not in the operating room, not when you're treating the patient in front of you, but in your career choice. So, yeah, now that I have hopefully made you guys question your life, existential life crisis come up, and you're just like, okay, what's going on? Why is she doing this? Let us do a little bit of an icebreaker. And if I can get you guys to screenshot this, or yeah, you can take a picture of it if you're tuning in from your laptops. And you can do this little bingo with me. Nice. Hi, Allergy. So I think, especially for me, COVID years was that kind of time where I just went through this whole rabbit hole of like, what am I doing with my life? I guess some of us might also feel that way. Anybody? Nice. I don't know if Achal was, I want to say she was in kindergarten at that point. Just teasing. I think one of the youngest members in our Heimat community. So yeah, quite interesting that you're here. Okay, how many? Sorry?
Toby. The youngest member is Toby,
Oh, that's true.
7 months old.
We're grateful for Toby for joining. But yes, okay, I am realizing that not many of you are not turning on your cameras. Please, if you can see my sleepy face, I think it's only fair. Nice. Thank you for turning on your camera, Daniel. How many of us here like contemplated quitting medicine or your job, whatever it is? Nice. Yeah, if you have not, you're either a psychopath or you have really strong willpower. So either way, good for you, I guess. Cool. Then let's move on to the next part. If you can, guys, and if you've taken a screenshot of the bingo, like please do share on social media. I've also tagged Handbag Medicine either on LinkedIn or Instagram or wherever you can find us. That would be quite nice to see what you scored on the bingo. Cool. So now let's just get this out of the way. How do you sound like one of the Illuminati, right? Because all this effective altruists keep using all these different terms. So what is it? EA is basically a sort of, like I said, a triad system for you to pass through the world's problems. So some problems are like band-aid fixes. For example, if you're just treating that one patient in front of you, and some work more like a vaccine, which is like preventing millions of people or at least hundreds of thousands of people from getting a particular disease. So what is the difference, or how do you sort of like calculate all of this? And impact is equals to scale times tractability times neglectedness. So scale, as you can probably see from this example that I've given here, 1,000 patients in clinic versus vaccine. Tractability is how solvable an issue is. For example, antibiotic resistance. That's pretty hard to solve, right? Versus malaria, you know that bed nets are a very effective solution for this. And then for neglectedness is how crowded is this area. Climate change, for example, super crowded. a lot of players in this game, whereas pandemic preparedness is severely underfunded. So this gives you a little bit of idea on what the STN framework is. And now for counterfactual impact. So I feel like, okay, all of us might have gone through this at some point in our life. Like, when you're messaging a romantic partner and, you get the WhatsApp notification that they have messaged you, but then you want to act cool and give it some space before you respond back, like create that absence, that exclusivity. But okay, to bring it to medicine, and something a bit more serious is, for example, if you're in the UK, your absence as a doctor will not reduce outcomes because there are enough doctors compared to the population. So that means you're a bit more replaceable. Whereas in Kenya, if a doctor doesn't show up, this absence can cost 62 lives in a year. So that's what counterfactual impact is. And hopefully this gives you a little bit of like base ground on what EA is. Can I just double check? Like, is anybody super lost? Have you heard of effective altruism, or is all of this like going over the top of your head? Does it make sense so far? Thanks. Yeah. I have only like 4 of you to get like feedback from. The rest of you, no thanks. Yeah. Okay. So now I'm going to need your engagement, guys. I have given a few options here. Which problem do you think is most neglected in healthcare today? These are just some suggestions. There are definitely more problems. Can you guys think of anything? You can either unmute or type in the chat. Which problem do you think is very neglected in healthcare? You can guess.
Maybe more maternal mortality rates, especially in higher income countries like America and the UK.
That's a really good guess. Thank you, Fish. Is that something you're interested in, Daniela?
Not particularly, because Black women are more affected. It's just something that's been on my mind.
Yeah, totally fair point. Ria, I saw that you unmuted. Do you want to take a stab? You're muted.
Dang it. Well, I was thinking of childhood obesity, but then also like lack of access to healthcare in general. And then also like pretty easily curable early stage cancers in the developing world soon to be a problem, I think.
Yeah. All really good points.
I think
Susanna?
it's a difficult question because everything we think of is likely to be less neglected because we've heard about it and we know about it. So for me, it's hard to judge without like numbers and some research. From those you showed us here, I think maybe mental health in some places, some regions of the world. Other than that, I'm not sure.
Nice. All really valid points. Like what we think is neglected is something that we probably have not thought of yet. That's a good one. Anybody else? I feel like mental health, Fabian will probably also agree since that is his area of expertise. We have Harsh here who's tuning in from Wales, who's working on suicide prevention. Do you think suicide prevention is the most neglected problem? Since you work in suicide prevention, do you think that's the most neglected problem in healthcare today?
Yeah, mental health is the one because it is not considered as a health compared to physical health, because physical health can be seen or like diagnosed, but mental health is not easy to assess and diagnose. So yeah, that is my take. Yeah.
So, like you guys mentioned, right, it's quite a difficult problem to quantify. But so 80,000 hours, which is this organization that does incredible amount of research and guides people to impactful careers, has done a bit of groundwork on this. So according to them, pandemic preparedness has only 1% of global R&D funds directed towards this. And obviously, as you guys know, pandemics have the potential to kill millions of people. And this could be easily preventable. So pandemic preparedness is one. And the other one is antibiotic resistance. So this has the potential to kill 10 million per year up till 2050. And only 0.1% of pharma R&D addresses it. Yeah, that gives you the kind of scale of what we're going towards in the future, and maybe serves a little bit of inspiration for those who are undecided in their careers or still looking what they can potentially specialize in. So, okay, this I blame me studying for the US family. I'm going to force you guys to go through this like very nerdy analogy with me, okay? So, you're all familiar at some point in your life, you've done this like enzyme substrate complex thing. And I wanted guys to think about healthcare in wealthy countries as an enzyme substrate reaction, where doctors are the enzymes, patients are the substrates. And at first, when you add more enzymes, obviously outcomes get better. But then at a certain point, it just plateaus because there's enough doctors, the system is saturated, and you reach Vmax. When you add more enzymes or you add more doctors, it doesn't really help with the outcomes. So, like I mentioned, in the UK, there's 300 doctors per 100,000 people. So it's already maxed out, and one doctor saves fewer than 0.25 lives, whereas a doctor in Kenya saves about 62 lives annually. So does this mean that all of us here should move to Kenya, should move to Pakistan, to some other lower middle income country? What do you guys think? Glenda's like, I already live in Kenya. Sorry, Susanna, I didn't catch that.
I said probably it doesn't mean that.
Yeah. Okay. I don't mean to guilt you guys, but the world is rarely a biochemical reaction, right? Like we can't simply uproot our lives and do that. There are some very incredible people who do it, who join organizations like MSF, Doctors Without Borders, which is pretty cool, but it's not always practical. And you also obviously have your own career aspirations and personal fit and all of that. So with that in mind, I keep throwing you guys into like really hard situations, but I promise this is much more fun than it looks. This is known as the drowning child thought experiment. So imagine this. You guys are a top doctor running through a park and you're on your way to the hospital for a life-saving operation that only you can do and nobody else. So on the way, you hear a child shouting for help and is drowning in a shallow pool. So I want all of you guys, either if your cameras are on, to like raise your hand, or you can use the raise hand function on Zoom. Will you stop to save them?
If we stop, the operation won't happen?
Yes.
Question?
You're on the way to your hospital for a life-saving operation that only you can do, and you see or you hear a child shouting for help because he's drowning in the pool in the park. Do you stop and do you save the child?
Anyone else around? Could other people potentially help? Or...
No. That's the point of the thought experiment, Achal. You can't recruit, you can't call a friend now. This is not Who Wants to Be a Millionaire. Will the patient still be stable? I don't know. I think, yes, he's going to save the child. Yes, Manisha is saving the child.
I don't know how to put my hand up, but I would also save the
Nice.
child.
That works. Great. We have a few hands. Ravi is like, I don't have the skills to save a child. I'm not going to do it. Okay, nice. A lot of people saving the child. That's great. Super altruistic of you guys. Now I'm going to add a nuance. What if you were wearing this super expensive Gucci suit and you saved for like multiple years? You bought this suit. It's super expensive. It is not waterproof. Are you still going to jump into the pool and save the child? And yes, you have to jump into the pool. And no, you cannot strip. Daniel is like, damn it. Okay, nice. Wow. Martin, that was deep. The cost of the life exceeds the cost of the suit, which is true. Okay, so we still have some altruistic people in the room. So, like I already kind of clarified earlier, right? Like, what if saving this child in front of you delays the surgery and that other life that the patient that you were supposed to save, they had signed all these consent forms, you had spent months going through their case, their life is lost in the process of you saving this child. And you know that for sure. Would you still stop and save this child in front of you? Thanks. Karthik is like, whatever's in front of me, I'm gonna save. It gets tricky, right? By the way, there's no right or wrong answers in this. It's just meant for you to like think about it. Yeah, Susanna is like this obligation to some patient. I think people are 50-50 on this. Yeah. So then again, I'm gonna ask you guys to think, what if this child is not in front of you and is in some war-torn country where you cannot see? And there are multiple pools, as we know. There is war in multiple different locations around the world today, but we hardly think about it because we always think about that one patient in front of you, right? And there is another nuance to it, which is, what if you could save 10 children instead by just donating your salary to impactful charities? Would you consider donating? Okay, now I think it's gotten a bit too dark. People are like, am I losing my license? Am I losing my money? What's going to happen? So just to bring a bit of humor to this, like if you're a radiologist or a dentist, please, we do not trust in your CPR skills. Do not jump in the pool. Just donate your 6-figure salary. I think that will be a lot more beneficial to all of us. So yeah, this is a thought experiment by Peter Singer, and I thought it was super impactful when I first heard this. And it really makes you reflect, right? Like our moral circles tend to expand the more we know information about the world. But if we are in our siloed bubbles, then we only care about what's in front of us. So I really appreciate you guys for coming here today. I don't know what you're doing on a Saturday afternoon, evening, whatever time it is. Clearly, none of us have a life, but at least we're doing something interesting together. So this, again, blame it on watching this show on Netflix. It's called Pantheon. Have you guys seen it? Have you seen
Which one?
this? Pantheon? Okay, I'm going to send a link to this because I think it's super cool. The Pantheon chopstick problem made me think of, you can see my screen, right? Yeah. Okay, I'm not going to play it because it's 2 minutes long, but this Dijkstra algorithm is basically a way on a thinking model on how to get through the shortest pathway to your goal. So your career is basically a roadmap. Dijkstra algorithm basically finds the steepest slope of impact. So this is what we do actually with HiMed's like career planning course. But for each of us here, when we got into medicine, there was some kind of like North Star, or in whatever career you have, there's something that you wanted to achieve, whether it's like saving more lives or alleviating suffering. So you have this. And then your second step is mapping all the edges. Like, what are the different options that you can do to achieve this goal of saving the most number of lives you can? Is it practicing in your home country? Is it earning to give? That means you donate a certain portion of your income. Or do you want to like completely shift to a new area, for example, biosecurity? Because now you've heard that pandemic preparedness is so severely underfunded. You're like, okay, maybe this is something that I should go into. And then once you have like this various different options that you think about, then you weigh the pros and cons. Like, should I focus on saving 100 patients locally, or think about how can I save 10,000 patients globally? And then obviously this sounds nice in theory, but how are you going to get there, right? Obviously, even if you quit your job now in medicine and join some global health career, you're not going to save 10,000 lives. So this sort of like thinking model helps you map out across the length of time how many lives you are going to save or whatever your goal is, and how feasible is this. And then the fourth step of this entire thinking model is to iterate, because sometimes you couldn't be wrong. You can quit your job and then you join like a global health or research career, and you're just like, oh my God, I hate this. I need to go back to the toxicity of medicine because medicine is toxic. You still have to like get that adrenaline rush sometimes, but that's fine. There's no judgment here. And the point is, there's so many different ways you can get to this various different decisions. So one possible way is our HiMed career planning course, where you have facilitators, you have weighted factor models that help you pass through all of these different decisions. Because I'm just giving you like surface level stuff. But yeah, there's a more structured way of going through this. And these are some of like the different high impact areas. Actually, we also do have an introductory fellowship, which is like an 8-week program that discusses all these various different areas in more detail. It has reading material, and you go through it with a group. And I guess it's a great way to give you like a buffet sampling of all these different areas. If you want mentorship in a certain area, we also do have that in our community. But yeah, there's so many different ways, and some that are not even mentioned, right? Like Daniela mentioned about maternal mortality, and I already mentioned about childhood obesity. I guess some of them are aspects of like global health, but what I mean is medicine doesn't chain you to one specific course of action. Like, you don't have to be chained to a hospital and work 80-hour work weeks. There's so many different ways you could potentially contribute, and doesn't necessarily mean that you have to quit medicine also to do it. There's ways to do both. So to give you, okay, maybe a little bit of break from me speaking, let us go into a few breakout rooms if you guys are open to talking. Is everyone okay to interact with each other? Okay, nice. I feel like there's only going to be one group that's interacting with each other. The rest of you guys, please. So you have $1 million. Unfortunately, this is hypothetical. And you have these 3 different interventions, which is building a new ICU, training community health workers, funding research. You have 5 minutes, put the timer, and I will break you out into rooms. Don't worry, you don't have to memorize. I will copy paste it.
Hello, Ganda. Did you get a picture of the roleplay task?
I didn't get a picture, but
Mm-hmm.
options were to
Do you want me to share it onto the chat if I... Oh, it's already there. Okay, that's it.
Oh, did you
Thank
get a picture? Okay, yeah, you can share.
you. Okay.
Oh, that was smart. Okay, but hi guys. I hope everyone's being nice and friendly to each other.
Yeah, we are.
You can, if you guys have time as well, do try to like squeeze in a bit of intros of each other.
Hi.
Does anyone want to go first for introduction?
I don't know.
Hello.
There's a, oh, hi.
Oh no, hi everyone. Sorry, I'm on the road, but just to give a brief intro, my name is Nduta. I actually work for Hymed as community officer. Sorry, I can't share my video. Nice to meet everyone. I think I've been hearing Daniela say a few things here and there. So yeah, I'm from Nairobi, Kenya, medical doctor, currently doing my internship. So nice to meet everyone. I'll
Nice to
pass it
meet
on
you.
to Glenn.
Hi, everyone. My name is Glenda, Nairobi, Kenya. Kind of stalled in my career, but hoping to start internship before the year ends.
Hi, so I'm Daniela. I am a third year medical student and I'm from London, in the UK. And yeah, I don't know really what I want to do. And there's a lot of talk about careers now that I'm in third year, so past the preclinical years. So I found high med and I'm just looking into it a bit more. So I'm just attending this talk. Anyone else here?
Hey, can you hear me?
Yeah.
Hi,
Yeah.
I'm Karthik, and I'm from India. So this is the first time I've joined a high med meeting. I know Vaishnavi. I'm a doctor from India. Currently work in the surgery. I've currently come to the UK to clear my labs and stuff. And I work in the surgery department back in India in a government hospital. So yeah, that's about it.
Nice to meet you all. So I think the task is in the chat. So how do we rank the three interventions?
I think I'd suggest that everyone goes ahead and says what they would allocate the money to and why. So let me start. I think I'd allocate it to training community health workers in rural Africa because when you look at these options, that one gives you like you get to reach more people and you get to prevent diseases before they actually happen. And at the end of the day, you get to save on a lot of money treating. So it's more on prevention, which makes a high impact.
Yeah. So what I was thinking is, I'm not sure what they're trying to achieve with the task, but just looking at the question, I was wondering if $1 million is even enough to target the whole rural Africa and do such stuff. And I was wondering if we could rather, even though I'm sure a lot of people want this, but build a new ICU. And that will give you a lot of running money to actually help with it in the long run.
Yeah, I see that point as well. I see both points. I was gonna say funding research, to be fair. Now I've changed my mind because the research might not actually go anywhere. It doesn't say that they will actually develop a new vaccine, a universal flu vaccine. So obviously funding research is obviously the first step, but it doesn't say that it will the end product will be a vaccine. So I think training health workers in rural Africa will be a good first step because that will probably they lack access to basic healthcare. So training people like in the community will help maybe prevent, like you said, Glenda. So I think I agree with you because and the ICU, I would say ICU in a low income country would help. But because it's a high income country, I'm sure there's many ICUs that people can access. Yeah.
I'd say the same as all of you. Personally, I would choose the training community health care workers in rural Africa, mostly banking my answer on the neglectedness portion, thinking about how far it would go into accessing, because I think people tend to not realize how rural Africa can be. There's some really rural areas. In Kenya, even just thinking about
Cool. So I was hoping that we will kind of like debate it out. So we have team one versus team two. I don't know if we'll have much of a debate. Imagine if you guys have the same answers. Okay, so team one would be Daniela's team. Daniela, would you like to share what you guys thought?
Yes. So, I think it was like the vote was 3-1 on the ranking of the first one, the first intervention. So we said training community health workers in rural Africa. And in terms of the STN model, we focused on the neglectedness part of it because a lot of rural parts of Africa are overlooked when it comes to, health initiatives, and also the scale because they lack access to basic healthcare. So training healthcare workers it's a direct impact on the health outcomes for a lot of people, maybe thousands. It depends on who lives there.
Makes sense. Okay, so I ranked it correctly, right? Number one is community health work. The second?
We didn't actually get to that bit yet. So
Yeah, so I'm not really sure what the ratio was on the answers because not everybody spoke, I think, but we unanimously agreed that the ICU one is to be put last,
Okay.
obviously. And then there was some disagreement about the community health workers in rural Africa and the research. And the arguments for the community health workers were, as Daniela said, and yeah, I think they're really important. Whereas the arguments for putting research first were that the scale is much, much bigger for the research, and even a small improvement in the cost maybe or effectiveness of a vaccine would have a tremendous impact of the world just because so many people get the vaccine every year. But there was one argument that I found really smart. I don't really remember who said it, I'm sorry, but about the knowledge spreading in communities, that because when we educate community workers, that it's not only those workers we educate, but they can spread that knowledge, ideas further. And I think that's really hard to measure, and maybe that's because that's why it's sometimes not mentioned, not taken into concern in 80,000 hours or AIM or open philanthropy research. But it's really important, so I wanted to share.
Thanks. So both teams have a number one, but not really decided on two and three. Maybe does anybody want to share any thoughts?
Yeah, we had
Oh, you had?
number 3 agreed.
Three is?
No, number 3 agreed. At the ICU. And
I see.
number 1, we didn't reach an agreement.
Yeah.
So
Okay. Glenda, Daniela, and who else was in your team? There was Karthik, who has disappeared.
I'm here.
Oh, you're here. Hi. See, that was a test. So, do you guys have any vehement objections? Does anybody think like building a new ICU in a high-income country? Anyone wants to play the devil's advocate, actually?
I think we should
Yeah,
close.
I'm sorry.
Ellery, were you saying something?
We have plenty of ICUs, and maybe we'd be better off with fewer beds sometimes, at least in Florida.
Okay, that makes sense. Karthik, you wanted to say something?
My argument was that even though $1 million sounds like a lot of money, would it be enough to actually even have an impact in the whole rural Africa? So that's why what I suggested into my team was that maybe build a new ICU and put that money into Africa.
That's actually pretty smart. Yeah, because the ICU can bring in more income and then that you can invest again into other like more public health initiatives. That's pretty cool. That's a good
Yeah,
argument.
but building the ICU is gonna cost like $1 million would pay for like 3 patients' hospital stays.
Yeah, that makes sense too.
And what if there are no healthcare workers to work in the ICU? Then be the
Efficient, yeah, or not
yeah.
trained enough. Yeah, lots of holes that we can poke in this. Thankfully, none of us have $1 million to donate. So a problem for another day, maybe tomorrow. So yeah, we are moving to like the almost final section of this. Just wanted to give you guys like a little bit of inspiration and examples of people in the HiMed community who are doing super cool things. So this is Akhil Bansal. He is one of the two co-founders of HiMed, and he began his career as a doctor in Australia. Then he founded HiMed. Like this is not linear, by the way. He has like way too many things. Strongly suggest that you stalk him on LinkedIn or read any of his articles on EA Forum. He helps in antimicrobial resistance. He's a policy fellow currently in global health. What else? He also sits on the board of multiple different charities that prevents violence against women and girls. Super cool guy. And what he does is he's actually, I forgot what is his specialization. Maybe I'll read if you remember, you can remind me.
I think it's emergency medicine.
emergency. Yeah.
Emergency, I think. Yeah.
He does emergency part-time while doing all of this. So I think it's maybe like 0.5 FTEs of medicine, and the rest of his time is like split between all these various different causes. And then we have Marie, who was our previous executive director. So she did her med school in Germany. Then she quit medicine to do fundraising for Doctors Without Borders. Then she went into consulting for about a year. Then she was executive director for 2 years until very recently, and she stepped down. And now she's going back into psychosomatic medicine. So this, like, I want to put it here as proof that I'm not trying to guilt any of you guys into quitting medicine. I'm just showing you that, multiple different options do exist. And we have Bell over here, also Dr. Australia. Before he even came to HiMed, he founded this organization called Born Clothing, which is like anti-malaria kind of clothing. I have no idea how it works. Definitely need it here in Singapore. And then he went through the intro program in HiMed and decided to step away from clinical medicine and join the lead exposure elimination project as program manager. And he very recently got promoted to industry engagement lead. And this is just like some of the very cool people that we have in our community. As you can see, we also have Ellery, who is head of giving. He's a Heme Onc fellow, I think. Very nice. I did my stalking on LinkedIn before the call. We also have like really cool people who are still in med school. For example, Carl. He is final year med student in Philippines, also volunteering for Healthy Futures Global, which is preventing vertical transmission of syphilis. We have Rafael, who is in our M&E team, and he does a lot of cool things, which I cannot remember at the moment. Something super niche about policy. If I remember, I'll put it in the chat. And we have Abbas over here, who's also a final year med student in the UK. He's actually running the UK conference that's happening on April 5th. So people in UK, if you're available, if you're in London, please attend the conference. It will be a super cool opportunity for you to network and meet interesting people. Actually, Bal, this guy, he is one of the speakers for for the London conference. So it'd be cool. And yeah, I hope that this talk was useful and you consider more ways to improve or increase your career capital.
This was super useful. Thank you.
Nice. So I'm gonna leave you guys with this Chinese proverb, but yeah, just to put it into context, like the best time is now to prevent another child from drowning in a preventable suffering. So sorry for all the guilt tripping, but I hope it gave you some like food for thought. And yeah, now you can start traumatizing your med school friends on the drowning child thought experiment. Thanks.
Thank you.
Thank
I
you.
actually at Thinker's lecture 2 days ago, so got traumatized over and over.
Yes, it's just a fact medicine. Is there any questions or any thoughts?
It was really cool, really brief. So you touched a lot of subjects in under an hour. I'm impressed in you.
Yeah, hopefully it was not rushed through. If anything, like I hope you guys are on the HiMed community. If not, I'll send out an email with the invite link so you can join the Slack. Yeah, and if you have any questions, you will be able to find.
Well, thank you.